My friends, I want to teach you about antibiotics because antibiotics are hard. There's kind of a problem actually with the way we learn this in residency. It goes a little something like this. You tell me if this is relatable. So we kind of are going through residency, and we're seeing different infectious syndromes. We see pneumonia. We look up on our guidelines and we see, okay, pneumonia, ampicillin. All right. And then you keep going through and you learn more infectious syndromes. Oh, admitting this patient with UTI, amptobra, okay. Cellulitis is Keflex, okay. And then you start linking infectious syndromes to antibiotics. And really, this is not the best way for us to do this, because for the most part, you can actually get by like this. But the minute there's some nuance to your case, you realize, oh crap, I don't know why we're on this antibiotic. I don't really know what it's treating. I don't really know what I'm not covering. And then you start to feel out of control. You start to feel vulnerable. You start to feel like you don't know what's going on with your patient. And those feelings suck. So I want to teach you about antibiotics so that you don't have to feel that way. And I think I can really help you be good at this. We can all be good at this, I swear. So we're going to learn these in bite-sized chunks. We're going to learn about how these antibiotics work, what they cover, and why. And by the end of it, my hope is that we won't pick our antibiotics based on infectious syndromes, but instead we'll pick our antibiotics based on the bugs that we know are probably involved. So with that, we're going to start with beta-lactam antibiotics and specifically penicillins. All right, so today we're going to talk about beta-lactam antibiotics. The reason they're called beta-lactams is because they all have this, a beta-lactam ring. Penicillins, Cephalosporins, and Carbapenems are actually all beta-lactam antibiotics because they all have this ring structure. So to understand how beta-lactam antibiotics work, you have to understand a little bit about bacteria and how they're structured. So if you remember, we have the gram-positive bacteria, which have one cell membrane and a thick peptidoglycan layer on the outside. And then you have gram-negative bacteria, which have two cell membranes and a thinner peptidoglycan layer in the middle. And remember, peptidoglycan is essential for maintaining the integrity of the cell. And then you have these things called penicillin binding proteins, which are basically responsible for building and maintaining those peptidoglycan layers. All right, so back to beta-lactam antibiotics. This is how they work. So basically you have your beta-lactam ring, and that goes and binds to your penicillin binding proteins. And that causes your peptidoglycan layer to become disrupted, and your cell goes and just dies and lyses and spills its guts everywhere. So that's it. That's how all of them work. Ceftriaxone, ampicillin, meropenem, all of them work the same. Isn't that crazy? But you're probably like, yeah, they're pretty different though. And you're right, they are. So here's the general structure of penicillins, cephalosporins, and carbapenems. And notice how they all have that common beta-lactam ring structure. That's why they kill bacteria the same way. But they're different in these R groups. So see, penicillin has this R group. Cephalosporin has these two. Carbapenems have these three. These are variable groups upon which chemists mess with the molecules and make them into different antibiotics. And these different R groups are what changes their pharmacokinetic properties, like what tissues they penetrate in. But also, these is what change their antimicrobial spectrum. Okay, so let's get into it. Penicillin G and V. Your key summary points for these are that penicillin G and V are good against streps, with some rare exceptions, bad against gram-negatives, with some rare exceptions, and do not cover staph aureus. Okay, so let's talk about why. So with gram-positive organisms, the penicillin binding proteins are sitting on this naked peptidoglycan layer. There's nothing stopping penicillin from being able to bind. So it's easy to kill gram-positives. That's why it's good against streps. But for gram-negatives, there's that outer membrane that's blocking penicillin from being able to access the penicillin binding proteins. And that's why penicillin's bad against gram-negatives. So now you might be asking me, hold the phone. You told me staph aureus is not covered by penicillin, but staph aureus is a gram-positive. What's going on there? To which I would say, great question. Well, staph aureus is a shady mobster who's going to send his little goons after penicillin. So he can produce what's called a penicillinase enzyme. And that's a beta-lactamase, which we'll talk about more in a future vodcast. So basically, it binds to the active site and inhibits beta-lactams. So that's why Pen G and V are good against streps, bad against gram-negatives, and bad against staph aureus. So because it has such limited coverage, you don't tend to use it as empiric therapy very often unless you're pretty confident you're dealing with a strep species. So for example, we use Penicillin G and V in many oral and pharyngeal infections because they're generally caused by streps. So acute bacterial pharyngitis, group A strep, is your most likely pathogen and is universally susceptible to penicillin. Simple periodontal infections, in that case, you have these weak alpha hemolytic streps that live in your mouth. You have oral anaerobes like streptococcus. Generally, these are well covered with Pen G and V. And then you have your targeted step-down therapy for things like invasive group A strep and neonatal group B strep infections once we've confirmed the bug, and then other streps like strep pneumo, group C, G, and F streps, other alpha hemolytic streps. The places you would not use penicillin are with staph aureus and empiric therapy anytime you're wanting to cover gram-negatives. Now, before I get in trouble with all the keeners, I will mention there are some rare exceptions. Here are examples of gram-negative organisms that are actually covered by penicillin. Presumably, they have a more permeable membrane. However, by and large, gram-negatives are not well covered empirically by penicillins. And the other little exception I'll mention is that some very rare strains of Streptococcus pneumonia and some of those alpha hemolytic streps can actually be resistant to penicillin. But we're going to talk about that in a future vodcast. So back in the day, you actually used to be able to use penicillin for staph aureus. But then we just kept throwing penicillin at it, until eventually you couldn't use penicillin anymore. And that's why they made Cloxacillin. Your learning point for Cloxacillin is that Cloxacillin is only used to treat staph aureus. Clox was designed specifically to work against the penicillinase of staph aureus. So here's what it looks like. And you'll see here this big, bulky side chain that's right beside the beta-lactam ring. That essentially gets in the way of the penicillinase binding to Cloxacillin, making staph aureus now susceptible because its penicillinase doesn't work. Now, there's a bit of a trade-off in here in that big, bulky side chain makes it a little bit less effective of an antibiotic overall. So really the only circumstance when you'll use this is against staph aureus infection. That is it. No other circumstance does it really make sense to use Clox. All right, that's it. Here's your summary slides. 1. All beta-lactam antibiotics have a beta-lactam ring. 2. The beta-lactam ring binds to penicillin binding proteins to lyse bacteria. 3. Penicillin G and V cover streps well, but do not cover staph aureus or gram-negatives, with some exceptions. And 4. Cloxacillin was made only for staph aureus. All right, next vodcast is on ampicillin and amox. You'll learn a lot about beta-lactamase. It's a good one. Check it out.